The next presentation is called Effects of Lung Recruitment Manoeuvres During Laparoscopic Surgery. The speaker is not the same as the speaker in your programme, and this presentation will be by Dr. Anders Larsson from Gentofte in Copenhagen in Denmark.
Good morning. It's really nice to be here, and I'm very happy to be invited to this meeting. And I'm going to talk about lung recruiting during lower abdominal laparoscopic procedures. And I'm coming from Copenhagen, and I'm working in intensive care mostly, or actually 100% the last 10 years. So this study has been performed by 3 of my other colleagues that are pure anesthesiologists, Dr. Samse, Jensen, and Kyst. But, of course, I've been in the background. Regarding Copenhagen, do you know this is a very close connection, Copenhagen, this meeting? Because 50 years ago, it was the birth of modern anesthesia, modern intensive care in Copenhagen. It was the first time it was positive pressure ventilation in critical ill patients. So it's 50 years anniversary. And modern intensive care was born in Copenhagen, Denmark. I will discuss a little bit the background, the study, and the conclusion. The background you have heard now very excellently from Professor Hedenstierna. But I have some remarks, although. As you now heard, atelectasis are common. Up to 90% after anesthetic procedures, and hypoxemia may develop. And it's not only anesthesia, because different type of procedures will make a difference, because laparoscopy seems to cause less pulmonary dysfunction than open procedures. And even more, that lower abdominal laparoscopy seems to be quite harmless. So, you see here is a study from Honduras, the British Medical Journal Anesthesia, time after surgery, FE1, and you see minor lower or lower abdominal laparoscopy. Yeah, they have almost normal function after 1 day in comparison with upper abdominal laparoscopic procedures, as cholecystectomies in this case. So you can always ask, why do this study? Why should we improve lung function in this type of patients? But we have heard oxygenation is affected by anesthesia in the high FiO2 during induction. And we also know that FRC and compliance are reduced by the procedure pneumoperitoneum. This is studied by Pelosi and Gattinoni and co-workers, and effects of carbon dioxide insufflation for laparoscopic cholecystectomy on the respiratory system. You can see compliance in decreasing here and during the procedure, and then up again. FRC is also decreasing by about 200-300 cc during the procedure. You can see also oxygenation, maybe not so much decreased during procedure, but if you look here to start with, we come back to Dr. Hedenstierna's explanation or discussion here. It's PaO2, arterial oxygen tension above the alveolar oxygen tension. It's 0.66. That is about 8-10% shunt to start with. So it may be a problem. And furthermore, animal experiments, if you just increase the abdominal pressure here with a balloon, you can see that if abdominal pressure increases, FRC decreases. And that is interesting is that you can see here also the transpulmonary pressures. Here is the lower part of the lung, the transpulmonary pressure at end expiration without insufflation. And this is end inspiration, but this is end expiration. But when insufflated lung, you see the transpulmonary pressure moves close to zero. And if it is zero, it's quite high tendency to cause atelectasis formation. Is it below zero, is by definition atelectasis. But what can we do about that? We come back to the animal experiments. Of course, you can try PEEP. Maybe it's useful. Here we have PEEP. This is a study from Anesthesia and Lodiger. If you have, it was a PEEP titration study. We see the shunt fraction here with a low PEEP 20 and with PEEP 15 it's 8. So maybe PEEP is useful. But our hypothesis was that we know that a recruitment maneuver combination probably will normalize oxygenation, improve chest-lung mechanics. We'll test this here in these type of patients. And the most interesting maybe, would oxygenation be maintained normal during pneumoperitoneum by these measures? And the third question is, because of animal experiments, and many of you use PEEP, is PEEP in itself effective to normalize impairments of gastric change and lung chest mechanics? So what type of recruitment maneuvers? We can use this discussed in insufflation up to 40 centimeters, 40 seconds. It's an old one. Then we have the more recent one. And now we heard that from Dr. Hidneshana that you can use 7 seconds. Or you can have repeated inflations up to 40 during a short period of time. We use this type of recruitment maneuver. 1 minute. Put on the pressure, peak pressure of 40 centimeter water, PEEP of 10 centimeter water, EI 2 to 1, 67% inspiratory time, rate of 6, and then ventilate the patient for 1 minute with this setting. 1 minute, it's not a long time. It will be 6 repeated sustained inflations with duration of 7 seconds each. We had 45 patients undergoing lower abdominal laparoscopy for minor gynecological procedures. They were otherwise healthy. And they were randomized into 3 groups. New recruitment and SEEP. New recruitment with 10 cm PEEP only, and recruitment and 10 cm PEEP before the insufflation. They were anesthetized with total intravenous anesthesia, propofol, remifentanil, or coronium. We used 100% oxygen during induction and then continue with 35% oxygen during the procedure. And except during recruitment maneuver, volume controlled ventilation, we have the C2 insufflated to an intra-abdominal pressure of 16, and the patient was placed in Trendelenburg's position. So, induction, arterial cannulation, blood gas, lung recruitment, SEEP, or nothing, then insufflation, and then blood gases every 15 minutes during the procedure, and then after exsufflation. And what did we find? We can see what type of patient did we have. They were about lower middle age, normal to a little bit high BMI, and short insufflation time, median about 30 minutes. So it was short procedures. But if you look here, did we confirm Dr. Hiddenstjärna's studies and other studies here? Yes, we did. We don't have the first blood gases because the oxygen concentration was not 35 when we start. We don't know what it was. But if you look here, lung recruitment, compare those 2 groups, only PEEP control with the recruitment of PEEP. This year, a huge difference. And more interesting is that it is about 27 kilopascals on 35% oxygen. That is actually no shunt. All atelectasis were removed by this maneuver. So that was effective. Was it effective to keep the oxygen well, good, during, maintain the oxygenation well during the surgery or the insufflation? Yes, it was. It was maintained to exsufflation. What about the 2 other groups? we can see here, it actually, that is interesting to note here, is that it is an increase in oxygenation or in PaO2 by insufflation. Then it's maintained and then it's down again to the same value as before. The PEEP seems to increase PaO2 somewhat, but you can see here, there are very few patients here after 45 minutes, so you should not be very careful to interpret these values. But recruitment maneuver was effective and it was maintained. Oxygenation was maintained during the insufflation. Dynamic compliance increased also, as suspected, and decreased during insufflation in all groups. But even during insufflation, it was higher than compliance was in the non-recruited group. Peak inspiratory pressures increased with PEEP, of course. But you can see one thing here that is also interesting is that the peak inspiratory pressures were lower with recruitment and PEEP than with only PEEP. And that is due to that the lung was less stiff. So the same tidal volume will cause less peak pressures. PaC2 was the same in all groups, increased during insufflation. Tidal volumes were also the same in all groups. So the question is, why does not oxygenation deteriorate by peritoneal insufflation to Delbos position? It should do in ICU patients. Put the patient in this position and press all abdominal component and pressure up in thorax. We can explain that it was a very good maneuver lung recruitment and PEEP in the lung recruitment and PEEP group. That works very well. But why did it not deteriorate in the other two groups? It even tended to increase by insufflation. It was actually statistically significant. And that confirms other studies. Why should it be like that? I have a hypothesis. And of course, it has not been proven. We know this, that diaphragm moves up in thorax. We know the pulmonary densities. There are atelectasis in the lower part of thorax. That has been shown by Dr. Hedensteiner and others. So if you see this nice picture, I seldom drawn it. You see here patient awake. Here is the diaphragm. Here is the alveolar size in both regions. And here have the ventilation. So the diaphragm moves quite well downwards, and the ventilation is distributed to the lower part or the dorsal part of the lung. And oxygenation is quite well maintained. During anesthesia, we know that diaphragm moves up in thorax to residual capacity, and we develop atelectasis here in the basal part. The ventilation is distributed to the upper part of the lung with low perfusion, and down here we have low ventilation and good perfusion. And we see a decrease in PaO2. What I think, and maybe can be discussed and studied by CT examinations, I don't know, is this, because no one has done that, but has know about it, explained this. If you see here, if you put in air or a CO2 in the abdomen, increase abdominal pressure, this part of the lung may not move further upwards in the lung. It was as far up as it could be. Then the pressure here must distribute to the upper part of the diaphragm. That will, of course, decrease the size of the alveolus somewhat, but it will produce that this part of the lung is more stiff and the lung, the ventilation is distributed to the lower part of the lung with better perfusion, and that will increase oxygen saturation. So, in summary, a recruitment maneuver is effective in combination to PEEP to normalize oxygenation and chest wall mechanics. And also, if you use these maneuvers, the oxygenation will be maintained with no shunt actually in these type of patients during the whole procedure. And PEEP is not effective at all. Thank you.
Thank you, Dr. Larsson. Any questions about laparoscopy? One of the, well, if I can just, while the microphone is going over there. What about the effect of blood pressure on the PO2? You showed what happened to PO2 after induction of anesthesia, with the decrease, but then an increase even in patients who had no PEEP. What about the effects of blood pressure and changes in actual shunt just due to hypotension following induction of anesthesia? Could that affect the results of that study?
If you have a severe hypertension and also have atelectasis, then maybe it should be hypotension on the not hypotension per se, I think, but bed perfusion. And I can see now, because if you have bed perfusion and bed heart function on the right side, then the pressure, the distribution of blood in the lung may be different. But I really don't know if that will affect the result. But maybe yourself have some comment on that.
Well, I think that if you have atelectasis and you have a certain amount of shunt, and if the atelectasis is in the lower part of the lung, you then produce hypotension. That same amount of atelectasis will actually produce a greater amount of shunt because the less of the lung is being perfused.
Oh yes, but that is a pulmonary hypertension. That in that case it cannot be the systemic hypertension.
But systemic hypotension is paralleled by pulmonary hypotension as well. Yes.
Van Böhm from Hamburg. I was part of the Tussmann study. Congratulations for this excellent result. The interesting thing is what you showed, that a PEEP of 10 seems to be adequate to maintain the lung open after a recruitment maneuver. And when you do laparoscopic surgery, or when the insufflation starts, all values decline a little bit. That confirms that when we did the Tussmann study, the 5 centimeters of PEEP were definitely not sufficient. So with your 10 of PEEP intraoperatively after recruitment, you're much more close to keeping the lung open. But our results now from morbidly obese patients where they do gastric banding all have a body mass index above 40. We find that we need PEEPs around 15 to 20 during the laparoscopic surgery. And during normal laparoscopic surgery, we would go from a PEEP of 10 that keeps the lung open. When they insufflate their abdomen, we go up to 15. And that's what we could confirm, that 15 of PEEP is very well tolerated during the high intra-abdominal pressure. But be very careful when they release for accident or whatever their intra-abdominal pressure, then you come into those severe hypotension phases. Otherwise, it's very well tolerated. So my advice would be 10 of PEEP during to keep the lung open after recruitment, 15 of PEEP during laparoscopic surgery, and even higher if the body mass index is increased.
Vennenberg from the Netherlands. Did you measure cardiac output changes during your maneuver? Because that could also explain your improvement in your blood gases. When your cardiac output decreases and your oxygen consumption decreases, you will get an increase in your PaO2.
We didn't measure cardiac output because this was in a minor surgical procedures, but in Swan-Ganz catheter type of patient, I don't think is really ethical.
We did measure cardiac output.
Yes.
Could you just wait for the microphone again?
In the morbidly obese patient, we did measure cardiac output, and the cardiac output was only decreased during the recruitment maneuver with the high pressures, but even a PEEP of 20 was very well tolerated, and the cardiac output did not decline by more than 15%.
And I have experience in intensive care patients, if you have high PEEP and the patient is adequately fluid resuscitated, cardiac output will not decrease.
Yeah, Göran Hedenstierna, may I hang on to the cardiac output issue? What happens to the pulmonary artery pressure during laparoscopic surgery? Because the PA pressure will also affect the distribution of blood flow, and that can affect the magnitude of shunt and oxygenation.
I don't know, but maybe somebody else in this audience know. Do you know?
There tends to be an increase in systemic blood pressure, certainly with upper abdominal laparoscopy due to release of vasopressin and angiotensin. And that may possibly increase pulmonary artery pressure as well, but I don't know if anybody's ever measured that. But it's certainly a theoretical possibility.
I'm not familiar with this procedure, so I have no experience. But if PA pressure goes up, and in particular, of course, relative to extra luminal pressure, you will have a redistribution of blood flow to higher regions, and that means that any collapsed region will have a smaller fractional part of the blood flow.
Just over here again, thanks.
Just a comment. We have not finally analyzed those values, but the interesting thing is that after recruitment, oxygen is the best vasodilator. So after you've recruited the lung fully, your pulmonary artery pressure goes down. On the other hand, of course, you have a CO2 effect, but they balance out quite well. We expected a much higher increase in pulmonary artery pressure, but we didn't find it. In those patients who did not have the insufflation, we saw that it decreased because we do it before the laparoscopic surgery. We do in the same patient, the same procedure, and then we do it during laparoscopic surgery. But the changes, we have a decrease in the pulmonary artery pressure due to the relief of hypoxic pulmonary vasoconstriction. So you have two effects.
Art Slutsky, Toronto. I have a question to look at the improvement in oxygenation, just looking at the gas exchange effect. First of all, is the minute ventilation identical during the insufflation period?
Yes.
Okay. And does this occur when you have insufflation without CO2 or only with CO2? I mean, how much CO2 actually enters the circulation during insufflation? This is from a non-anesthesiologist. Does CO2 increase? And because there is data in the literature to show the effect of CO2 improving oxygenation, probably by a non-pulmonary mechanics effect.
The C2 did increase somewhat during the insufflation, and how much C2 really in milliliter per second, I don't know, enter the circulation, but it did increase. And it usually does increase during these type of procedures somewhat, but the ventilation was maintained the same during the procedure.
Identical respiratory rate, everything was identical?
Oh, the respiratory rate was identical, yes.
There is some data to suggest that increased PCO2 might improve oxygenation by increasing collateral ventilation in patients, and that just another hypothesis to explain what's going on here.
It may be so.
Russos. Your experiments with insufflation abdominal insufflation is very interesting indeed. One way of explaining this, as you said, is really to change the distribution of ventilation in the lung. You didn't measure lung volume after insufflation, of course. You didn't have a CT. Did you measure with a magnetometer at least the PA distance of the chest wall? In other words, whether via the area of opposition of the diaphragm you inflated the rib cage and therefore you pull up the ribs and you distribute a better ventilation in the lung.
As I said, we just measure tidal volumes and pressure, so maybe your explanation is correct, but I don't know.
And the tidal volume was not different before and after?
It was not different.
Dr. Larsson, thank you very much.
Okay.